to give this talk. Do you see the slides now?
Yes, it's clear.
Okay, good. So basically, today we'll go over important ECGs or interesting ECGs. Some of them are actually very basic for you, but always common is common. So we'll start with the common things and then go to less common. And as you can imagine, ECG is important when it plays a role in the diagnosis and management of the medical condition we are dealing with. So ECGs of ischemia, infarction is important to make distinction between ST segment elevation and non-ST segment elevation. Myocardial infarction is based on the ECG plus history plus labs. So ECG is integral part of that. Arrhythmias again, for tachy and brady. So if a patient has heart rate 150, it could be sinus tachycardia, it could be atrial fibrillation, could be atrial flutter, could be ventricular tachycardia. ECG is the one that can tell you the diagnosis or help you in making the diagnosis. Same for bradycardia, heart rate of 45, could be sinus brady, could be junctional, could be patient with complete heart block and ventricular rhythm. For conduction abnormalities, heart block, second degree, third degree, we make it by the ECG. Electrolyte abnormalities like hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia, especially when it is life-threatening, it's important to recognize it. Pericarditis and infections is an important differential diagnosis of myocardial infarction. So ECG pericarditis is also important for that regard. Medications effect and side effects. So for example, if you're starting patient in sotalol, then we follow the QTC. And for side effects, for example, if the patient has long QT interval or is having arrhythmias because of that, ECG is important. And ECG also in certain conditions might be rare, but is associated with high morbidity and mortality, then it's important to recognize the ECG pattern. We'll do it as cases, mainly looking for diagnosis. And I need actually your participation and input in that. So we'll start with the first case, 65-year-old man. He's in emergency room because of chest pain. And this is the 12-lead ECG of this patient. Any volunteer?
Okay. So in this ECG, I can see a clear ST elevation in lead 2, lead 3, lead AVF. And there is also some ST abnormalities in AVR, AVL, which looks like ST depression. I'm not sure if it's really significant. And we also have, that's the clear abnormalities in this ECG.
Okay, so what is your diagnosis?
So those leads usually represent the inferior aspect of the ventricle. So this is the ST elevation. This is an STEMI in the inferior wall.
Okay, excellent. So, okay, I moved the X-ray. This is actually, you got the diagnosis right. But if I ask you now, is this patient in sinus rhythm or atrial fibrillation? Do you know?
It looks sinus because there is P wave before every QRS.
And is he conducting or is there any problem with the conduction system?
Can I see the ECG again, please?
Okay, that's the only reason I moved it, just because clinically, actually you are excellent, you're doing a great job. However, also to be systematic, so you will not miss important things. So for example, those patients with inferior MI, they may present with complete heart block. And if somebody just fixated that, okay, this is acute inferior MI, for example, take them to the cath lab, or if cath lab isn't not available, give thrombolytic, we may miss important conditions with it, like complete heart block. This patient is actually perfectly sinus rhythm and regular. There's no block. But what I meant, if you start systematic, then you won't miss any other diagnoses, because sometimes the patient may have more than one diagnosis. So this patient clearly has an acute inferior ST segment elevation, myocardial injury. We say injury, not infarction in this case, just based on ECG reading, because we don't see pathologic Q waves. He did not have Q wave yet. However, management is the same as infarction. And you mentioned some changes there, which is reciprocal changes. So what do you think about V1, V2? There is ST segment depression, T-wave inversion. What do you think of these changes in V1, V2?
Yeah, those changes are consistent with imbalance between supply and demand, but it didn't reach the ischemia level.
So we know this patient already had the coronary artery disease, but this is additional to it. So is it just reciprocal change, or could be something else?
It could be. This leaves represent the anterior wall. So
Right.
it could be a lesion affecting both the anterior wall and the inferior wall. For example, if this patient is having left dominant system and he has a lesion affecting both the LAD system and the CERC system, he could, but the CERC system has complete occlusion and the LAD doesn't have a complete occlusion. He might present with a picture like this.
Okay. So what area supplied by the common for this right coronary artery, of course. So what are the areas supplied by the right coronary artery?
If it's dominant, it will supply the right ventricle mainly, and in most people it will also supply the SE node, the AV node, and if it's dominant, it will also supply the inferior aspect of the septum or the
So the posterior wall. Yeah. So if there is infarction, because the right coronary supplies the inferior wall, supplies the posterior wall and the RV. So if there is infarction in the posterior wall with the inferior, how will you see it in the ECG, in the 12-lead ECG?
Yeah, it will be shown as depression in the anterior leads.
V1, V2 would be depression because it is mirror image. We are looking anteriorly and the infarction is posterior. So how can we confirm if there is posterior infarction in this patient?
We can put the ECG leads in the back of the patient.
Excellent. Yeah. So the other part is the RV. Okay, we know it supplies the right ventricle. How can we know if the right ventricle is involved or not?
We can put the leads on the right side.
Right-sided leads. Excellent. So basically, you got this right there. So it's right coronary artery, and you know this very well, but just as a reminder, it supplies the inferior wall, it supplies the RV, and mostly when it is dominant, the posterior wall. So we need actually, when a patient presented with inferior ST segment elevation myocardial infarction, to be sure if there is RV involvement, right side, by doing right-sided ECGs, or if there is posterior extension by doing posterior lead ECGs. Inferior actually MI with RV infarction is not uncommon. 40 to 45% inferior MI may involve right ventricle. It's important to recognize it because it is a huge infarct. It involves the inferior wall of the left ventricle and the right ventricle itself. Mortality is higher than just pure inferior MI. Typically, they present with hypotension, raised JVP, clear chest, so there's no left-sided failure, and they need actually lots of fluid to maintain their circulation. So one of the exceptions, because generally with MI, we avoid fluid not to push the patient in heart failure. In this condition, we have to give lots of fluid to maintain circulation. As you mentioned, we do the right-sided lead ECGs. The diagnostic is V4 in the right side. I'll show you how it's been done. So basically, either just to take the V4 from the left side to the right side, and if it is 1 millimeter or more in this lead, there is RV infarct with the inferior wall MI, or you can do the reverse, all the leads on the other side. And this is another example here of inferior MI, as you can see clearly, and the patient here is sinus rhythm and normal axis. But what you see here is V1, there is a segment elevation actually in V1, V2. So what could it be?
I would suggest raising hands if anyone like to answer.
I cannot see those, unfortunately. So if somebody is want to answer, just unmute yourself and go ahead, please.
Could it be anterior MI?
Okay, so one possibility is V1, V2 is the septal area, which is also supplied by the left anterior descending artery, so it could be. But how common to find total occlusion of the right coronary artery and also part of the left anterior descending artery at the same time? It's of course uncommon. So what is the differential diagnosis? But this is one of the differential diagnoses, of course. the aim actually of this one, just to think about it, if you have inferior ST segment elevation MI and there is elevation in V1, V2, remember these are septal leads, but also they are looking to the right ventricle. So in some patients, you may have actually ST segment elevation in V1, V2 representing RV infarction, which typically we have to do right-sided ECG to confirm it. But when you see it also elevated in V1, V2, it is raising suspicion that there is RV infarct. The other clue in this ECG that the magnitude of ST segment elevation in lead 3 is more than lead 2. If you take it from baseline to the area here, from baseline to there, it is more. This mainly indicate right coronary artery involvement, and with right coronary involvement, there is also right ventricular infarction. So sometimes you may have some clues in the ECG before doing the right-sided ECG that there is right ventricular infarction. This is actually when the right-sided lead ECGs is done. You see in the RV4, there's significant elevation. So V1, V2, ST segment elevation in this case indicate RV infarction. Sorry, you have a question?
I just want to confirm the point. So if the ST elevation in lead 3 is higher than lead 2, this indicate an right coronary
right
lesion, and
more likely, and with that, most of the time they may have right ventricular infarction. Yeah, not very specific and sensitive, but one of the clues if you see it in ECG. So in that case, we confirm it by doing, in this case, V4R, and it showed ST segment elevation in V4R, so clear right ventricular infarction plus the inferior wall myocardial infarction. Okay, this is how the posterior lead is being done. If the machine is 15 leads, then you have V7, 8, and 9 posteriorly. This is at the same level of V6, but posterior axillary line. And this is paraspinal, and this is with the scapula. For this is actually, again, another ECG for inferior MI. Not as obvious as the one before, but you can see there is 1 millimeter elevation here and there, because, you know, for MI, you have to have 1 millimeter or more in 2 contagious leads, two leads from the same area, except V1 to V3 has another criteria based on age and gender. But in this case, it makes the diagnosis, and you can clearly see also significant depression in V1, V2, V3. And by doing the posterior lead ECGs, we have elevation in 7, 8, and 9, which is posteriorly looking, so it confirms the posterior infarction. So with inferior MI, you may have right-sided infarction, right ventricular infarction, and it's important clinically to make that diagnosis. You may have posterior extension, and again, it's important to make this diagnosis by doing additional ECGs. Any question about inferior MI? Okay, so let's move to the second case. A 55-year-old gentleman present with chest pain, and this is his 12-lead ECG. Any volunteer?
Can I volunteer?
Yeah, please go ahead.
So this looks like a regular rhythm with normal rate, sinus. The QRS is narrow. And the PR is not prolonged, the PR interval. This ST segment, it looks like there is ST segment depression in the inferior leads. And it looks like there is also elevation in the anterior anteroseptal lead.
Yeah, V1, 2, 3,
4 and 5.
Yeah.
Also, the T wave looks hyperacute in V2 and 3 and 4.
So what is your diagnosis?
I think it's an anterior ST elevation MI. That's it. But for the T wave, I think it just went up with the ST segment. It's not like
hyperacute T wave. Two differential diagnosis generally is hyperkalemia or ischemia. And if you have ST segment elevation, this hyperacute T waves goes, of course, with the myocardial infarction, as you mentioned. So it's excellent. But how about the lead 1 and AVL? What do you think of them?
The 1 and AVL are the high lateral leads, and they also have ST segment elevation. I did not notice.
This patient has anterior and
lateral.
So again, it's LAD, left anterior descending artery, but it's extensive myocardial infarction. As you know, V1, V2 is septal area. 3 and 4 anterior wall, V5 and 6 lateral. In this case, you have 5, but you don't have 6, so only one lead. You have to have 2 leads from the same area. But if you look to the high lateral one and AVL, as you clearly mentioned, there is at least 1 millimeter elevation. So there is anterior and there is lateral, so anterior lateral myocardial infarction. There is actually Q waves here, so you can call it by ECG infarction. And left anterior descending artery is the artery that supplies the anterior wall, as you know, and this is the largest artery in the body. And the infarction depends on the localization. The more distal, the less damage. The more proximal, the more damage. So that's why presentation can be different and variable. Okay. So the second case is straightforward. So we'll move to the third case. A 62-year-old. He has diabetes. He had previous cabbage. He's in emergency run now with chest pain. Cardiac enzyme CK450. Troponin is 90. So who wants to take this one? Any volunteer?
Can I try again?
Yeah, please.
So the rate here, he looks tachycardic with regular rhythm. It's sinus. The QRS is narrow. The T wave, the PR segment is not prolonged or short. The T wave looks inverted in the anterior and septal and lateral and high lateral leads. The T waves are inverted. They are in the high lateral, they are flat. It's in one it's inverted, and AVL it's flat. Also the inferior leads, the T waves looks different. It's inverted.
Yeah.
These are the only things I can notice.
So what is your diagnosis?
It looks like
history.
It's an anterolateral ischemia.
Mm-hmm. So is the diagnosis here is unstable angina or ST segment elevation MI or non-ST segment elevation MI? Which one would you choose?
I would choose ECG changes with troponin that is raised at non-ST elevation MI.
Yeah. Yeah, you're right. So basically, myocardial infarction, not always ST segment elevation, as you know, it could be non-ST segment elevation. And how to make distinction if the patient presented with typical chest pain, and like this ECG changes with no ST segment elevation, it could be ST segment depression or T-wave inversion. And then you have positive cardiac enzymes. We are dealing with non-ST segment elevation myocardial infarction because there is already myocardial injury. If it is negative, you are dealing with unstable angina. Generally, management is the same for unstable angina and non-ST segment elevation MI. Initially, you start antiplatelets, you start heparin, you rate control them, and then decide for early invasive or late invasive based on the patient condition. So basically, this is non-ST segment elevation myocardial infarction. Moving now from ischemic ECG changes, this is a 55-year-old lady who has syncope, and this is the 12-lead ECG. And we have different possible causes. So again, any volunteer to take this ECG?
Okay, I'll start.
Please. No.
So in the ECG, the obvious thing is the rate. We have 1, 2, 3, almost 4 big squares between the P wave and the QRS. So 300 by 4, the rate is in the 60s. So he's a bradycardic, and there is now the reasons of bradycardia could be sinus and could be other causes of blocks. So to know that, we have to look at the PR interval and the relationship between the P wave and the R wave. So if we go from lead 1 to lead 2, 3, there is P wave, then QRS, then AVR, P wave, QRS. It looks like there is a P wave before every QRS. So, and if we go in lead 2 and follow the strip, there is P, QRS, and then the PR interval is changing actually.
Yeah.
So here, now what we can do, we can check the PP interval and the RR interval, and I think it's constant. So the PP interval and the RR interval are constant, but there is a dissociation between the P and R waves. So this looks like complete heart block or third degree AV block.
Excellent. Let me see. Okay. So basically, as you started, right, the patient is bradycardic. So that's why actually, if you start with the rate and regularity, it can give you the very helpful and can in the diagnosis. So the patient is bradycardic, and clearly, as you mentioned, we have to be sure what is the cause of that. One thing I did not mention earlier, but as I'm sure you are familiar with this, in this case, the layout here is the limb leads and chest leads, and you have 3 rhythm strips there. So for regularity and for rhythm, we make it through these 3 rhythm strips. So if you follow, for example, lead 2 here, we see a hump there, and there is no P wave for this Keras complex. There is a P wave there. There is another P wave here at the end of it. If you map them, as you mentioned clearly, they are the same. And if you map the RR, they are the same. So what it tells you that atrium and ventricle, they are dissociated. If you take this P wave to this P wave, the rate is about 70. And if you take this R to this R, the rate is lower. So there is bradycardia. So they are totally dissociated. So we are dealing with the third degree AV block. The atria is run by the sinus node, but the ventricular rate is, the ventricle is now from junctional area because you see it's narrow Keras complex and the rate is between 40 to 60. So it's coming from the junctional area. So you're right, this is third degree AV block. And of course, if there is no reversible cause, this would be an indication for a permanent pacemaker implantation. Next case, a 60-year-old man with palpitations. And again, this is the 12-lead ECG. And the question is about what is your diagnosis?
Okay, so this patient is having a bradycardia with almost a heart rate of like in 40s.
Mm-hmm.
Yeah, and it's regular.
Right.
Okay, and there is there is a B wave preceding every QRS, but there is a drop beat with the B wave.
Yeah.
And the BR is constant, I guess.
Yeah, they're constant, you're right.
Yeah, I think Mobus type 1.
Okay, so what is the usual in Mobus type 1? What is the characteristic of Mobus type 1?
It will be regular with a drop beat and constant BR interval.
That's actually Mobus 2. Remember, Mobus 2 is the one with the fixed PR and drop P waves. Mobus 1 usually gradual PR prolongation and then drop of the P wave. So this more, if you think about it, if Mobus 2, but is this real Mobus 2? I think the question in Mobus 2 usually have PR fixed, and then drop. Then fixed, and then drop. In this case, you have one conducted and one non-conducted.
Is this 2-to-1 AV block? Because there is P.
The name comes from this one. Yeah, exactly. We have 2 P waves, then 1 QRS complex. We have 2 P waves, 1 QRS complex. 2 P, like if you take this one, 2 P waves, 1 QRS complex. 2 P waves, 1 QRS complex. So this is called 2-to-1 AV block. It's actually a form of second degree AV block because we see there's conduction and no conduction intermittently, but we cannot call it type 1, second degree type 1, because we don't see PR prolongation then drop. We cannot call it second degree type 2 because we don't see PR fixed, and then drop. We see one conducted, one non-conducted. And by the way, there is right bundled also in this case. So this is called 2-to-1 because it could be Mobus 1, it could be Mobus 2. Clinically, what we do, we exercise the patient. If the conduction starts to improve, like 2 conducted and then 1 non-conducted, or we give atropine and conduction start to improve, this is at the level of the AV node because this is where it's affected with exercise and with atropine. And this is most likely to be Mobus 1. If we're doing that, the block is more like you have 3 P waves with no conduction then you know this is infranodal and this is more likely to be second degree type 2. So that's why we say 2 to 1, because you cannot tell from ECG if it is Mobitz type 1 or type 2. And this is again a form of high-grade AV block. By the way, if you have a Holter and we see 2 to 1, and most of the time patients in Mobitz 1 and Holter, most likely 2 to 1 is Mobitz 1. If we see in the Holter Mobitz 2 frequently, then this 2 to 1 could be Mobitz 2. So ECG itself cannot even give you a diagnosis. So that's why we call it 2 to 1 AV block. We know it is one of the second degree type block, but we cannot differentiate it's Mobitz 1 or Mobitz 2. Okay, excellent. We'll move to the next case, an 80-year-old female with dizziness. And this is rhythm strips. So from Holter, we have lead 1 and lead 2, and this is continuous recording. So what is your diagnosis?
Looks like sinus pause.
Mm-hmm.
So we have irregular rhythm, and then
irregular rhythm, right? And then we have this pause, as you mentioned, sinus pause. And then after that, what is this rhythm strip here?
and then back to sinus.
And sinus brady, actually, if you 1, 2, 3, 4, 5, 6, 7, yeah, less than 50 for sure. So if you see this tachycardia and then pause and then bradycardia, what do you call this?
Sick sinus.
Sick sinus, which is the common variant of sick sinus in elderly tachybrady component. So the patient irregular here, AFib. One may argue because it looks like flutter in this lead, but we have only 2 leads. So if you say it's flutter with variable conduction or atrial fibrillation with variable conduction, both will be okay. But it's more of fibrillation. And then when this stops, normal people actually, when they have fibrillation or flutter, you see post-operatively, for example, they go back to sinus within 1.5 seconds. If it takes long time to come back to sinus rhythm, this indicates the sinus node is not functioning normally. And typically they have also bradycardia. So that's what we call tachybrady syndrome. And in between they have long pauses. This is the common form of sick sinus syndrome in elderly, tachybrady syndrome. And of course, if there is no reversible cause like medications or electrolyte abnormalities, and they are symptomatic, then they need a pacemaker.
Mm-hmm.
Okay. Next question, 50-year-old female with no symptoms, and this is the 12-lead ECG. She's in the clinic for routine follow-up.
Okay, so I will please. So in this ECG, the RR interval looks almost, no, it's not consistent. And okay, and the rate is in the 50s, 60s, 70s.
Mm-hmm.
The obvious abnormality here is the absence of P wave. I don't see a P wave actually.
There's no P wave, and it is irregular rhythm.
Yeah, I think this is an atrial fibrillation.
Excellent. So in that case, it's very common ECG. You will see even most of the actually post-operative AFib is common. So irregular rhythm, narrow KRS complex, no clear P wave. Then we are dealing with atrial fibrillation. And atrial fibrillation could be fast initially, but if the patient on medications or have AV node problem, the rate may not be fast. How do you calculate the heart rate in atrial fibrillation?
In atrial fibrillation from the R waves.
Because if I take this R to this R, it is very slow. If I take this R to this R, he will be like, okay, with the normal range. So how can I know the exact rate?
We have to take many R's.
They're actually the best way.
If it is irregular, we have to count the R waves and then multiply them by 10. If regular, 300, and then the squares between the R waves. But this one is irregular. We cannot apply the 300 divided by the squares.
So what you can do, if the sure. Sorry, go ahead, please.
I was just saying, if it's a 10 seconds strip, we count the R waves and we multiply by 6.
Exactly. If it could be 6 seconds or 10 seconds. So that's why you have to make sure what is the length of that rhythm strip. And of course, each keras complex is 1 beat. If it is 6 seconds, you multiply by 10. If it is 10 seconds, you multiply by 6, and then you get the rate. This is like average rate. Excellent. Okay. A 44-year-old man with palpitations. Of course, we're here just about ECG discussion, so we'll just concentrate on the findings in the ECG, not the clinical aspect of the disease. So a 44-year-old male with palpitations, what do you think the diagnosis based on this ECG?
Atrial flutter.
Why flutter?
The patient is having the B wave and it is tacky with the sawtooth appearance. So most likely flutter.
You're right. Actually,
and it's regular.
It is regular initially, but look at the end there. You see that part of the rhythm strip? That's why actually rhythm strip is very important to follow it all the way. Then it starts actually to give you the diagnosis at this point when it becomes irregular. When it is regular initially, rate is about 150. We cannot be 100% sure this is a flutter wave, but I agree with you. Once we follow it up at the end, it's one of the differential diagnoses. Of course, 150, you have to think about supraventricular tachycardia or atrial flutter with 2-to-1 conduction. But at the end here, we see that flutter wave, the sawtooth appearance. So this actually confirms that this is atrial flutter with fast ventricular rate. The previous one was atrial fibrillation with controlled ventricular rate.
Okay.
The P wave shape is constant, meaning that it's a flutter wave. Yeah.
Exactly, because it's constant. And in this case, actually, we don't usually call it P wave because, you know, the P wave is atrial depolarization, which is happening from the sinus node. In this case, it is macro re-entry, so re-entry in the right atrium. So once we are sure, it's like this, we call it flutter waves. The difference is not the same as the P wave when the sinus node activates the right atrium and then left atrium, and then we have rounded shape, clear P wave. This is one re-entry circuit, and then another re-entry, then conducted. Here, one re-entry, conduct, one re-entry, conduct. Here, 1, 2, 3, 4, and conduct. So it's called flutter wave. So this is a atrial flutter with fast ventricular rate. Excellent. And this is just to show you that sometimes if you have actually block like this one, the flutter wave can be more obvious. So sometimes if you give IV adenosine to block the AV node conduction, you can see something like this. The flutter wave will be more obvious. And then you see the keras complexes in between. So that is more typical flutter.
Doctor, I have one question regarding the previous image.
This one or this one?
No, the one before, the first atrial flutter, before the adenosine.
This one, yes one.
I cannot see it, but in the first one, in the atrial flutter, the strip rhythm in lead 2, the last 4 or 3 beats are different from the chest leads in V5 and V6. Why is that, the morphology?
Sorry, just to make sure, you see the same, this is the ECG you are meaning, or you don't see it now?
No, I cannot see it. The one before it.
This one?
Unfortunately, still I cannot see it.
No, I did not show.
Yeah, this one, yes, this one.
Sometimes it takes a few seconds to show it. So what was the question, please?
The lead 2, the strip rhythm, the last 4 beats are different from the chest lead. Specifically, I mean V5 and V6. I cannot see the P wave and the QRS are not in.
Actually, the re-entry here it may not be seen in all the leads, and that's why if I look to these leads, I may think of actually more of atrial fibrillation because there is no obvious flutter waves. Then if you go down, we have 1, 2, or 3, we see it very clear. So even for P waves, you cannot see it in one lead, you have to look for others. Flutter wave the same. If you don't see it in one lead, look to the other. So it will not be the same. The re-entry circuit depends on the location with the right atrium, left atrium, the usual clockwise or counterclockwise, which is isthmus dependent, or if it is around the scar. So it will look different from lead to lead. It will not look the same on all the leads. Does that answer your question?
Yes, yes, doctor. Thank you.
You're welcome. So we'll move to the next one. 25-year-old male and with palpitations, and this is the 12-lead ECGs obtained during palpitations. What is your diagnosis? This is very common to see in emergency room.
SVT,
Okay, and why you say SVT?
narrow complex tachy.
Narrow complex tachycardia rate here is about 230, yeah? And it is
Yeah.
regular. And do you see clear P wave?
It cannot be seen because of the
Yeah, so there's
tachycardia.
Yeah, exactly. So if you see narrow KRS complex and it is regular and there is no clear P wave, then we are dealing with SVT, supraventricular tachycardia. So is supraventricular tachycardia a diagnosis or a differential diagnosis?
Differential.
So what could it be? I mean, what diseases we call them SVT, supraventricular tachycardia?
like atrial atrial arrhythmia.
Atrial tachycardia is one, yes. And the other two conditions?
Re-entry tachycardia.
Re-entry, which is AV nodal re-entry or AV re-entry with accessory pathway. So typically SVT is three differential diagnoses. Could be AV nodal re-entry, re-entry in the AV node, and this is the commonest in adult population. In pediatric, they have the pathways more common. Second is AV re-entry, which is a pathway. The third is could be atrial tachycardia with long conduction, so the P wave is hidden within the T wave, so you don't see it. In this patient, actually, if you look carefully, there is notch there at the end of the QRS complex, and there is like a deep S wave here. This is actually the retrograde P wave, and this, if you see something like this, is more likely to be AV nodal re-entry.
Retrograde because it's coming from down up.
But exactly, because
the
the atrium is activated from below up. The re-entry is in the AV node, so it goes to the ventricle and goes to the atria. Atria is activated retrogradely, so it has to be negative in inferior leads. So if you think about the terminology supraventricular, it includes any arrhythmia that conducts down the AV node. So in general terminology, it includes atrial fibrillation, atrial flutter, AV nodal re-entry, atrial tachycardia, and accessory pathway AV re-entry tachycardia. However, I showed you example of ECG and atrial fibrillation and the flutter. Most of the time, you can actually make the diagnosis from the ECG, and the management is the same. Rate control versus rhythm control, anticoagulation depends on the patient risk factors. So they are taken out. And when we mention SVT, mostly in our mind, we are talking about the three differential diagnoses of AV nodal re-entry, the entry in the AV node, slow and fast pathway in the AV node, accessory pathway, AV re-entry, or atrial tachycardia with long conduction. Okay, let's move to the next case. This is a 45-year-old and female, and she's complaining of dizziness. So what do you think? Any volunteer?
Torsade Dupont.
Why Torsade?
يعني wide complex and the shape of the waves itself.
So it is wide.
يعني ventricular tachy with يعني wide complex Torsade Dupont. I'm not sure.
By the way, you started right. And by the way, most of the time, if you start describing what you see, you will get the diagnosis. So clearly you mentioned it is wide KRS complex and it is tachycardia here. By the way, it started with sinus rhythm. We have a BVC, then this is started all over. So it is wide. If you see wide KRS complex and the rate here is about, let's say, maybe more
150?
than 180, yeah. So it is fast. So first differential diagnosis would be a ventricular tachycardia. Torsade, remember, it's a polymorphic VT. So is this a polymorphic or monomorphic? Monomorphic. So monomorphic ventricular tachycardia is mostly scar related or could be triggered activity or automaticity, but doesn't generally differ. So this is monomorphic wide KRS complex tachycardia. If you look carefully, there are certain humps there. You see this one, which is not in the others. And these are actually P waves. So we have dissociation between the atrium and the ventricle. This is the AV dissociation. So it is monomorphic ventricular tachycardia. And if you look to the beginning of the tracing, the patient was sinus, BVC started the tachycardia, it terminated here, and then two sinus beats, and again a BVC. Okay, if you look to this, what is the morphology? Is it more of right bundle or left bundle?
Right bundle.
Look to V1, it is QS. There is no R wave, yes? And it, of course, it is wide. So this is actually a typical left bundle. In right bundle, you have RSR in V1. In this one, you have deep S wave, so it is left bundle-like. And when it is left bundle, it means that the right ventricle is activated first. So the origin of this wide Caras complex tachycardia is coming from the right ventricle. If you have right bundle, it means that the left ventricle is activated first, like in right bundle, so it would be left ventricle. So in this case, it's left bundle, so it's coming from the right ventricle. If you look to the inferior leads, they are positive, so it's coming from the base of the heart. So this is one of the common diagnoses we see, which is right ventricular outflow tract, VTAC. If the echo is normal, this is diagnostic because generally they have normal structural heart, but they have VTAC started in the outflow tract. So left bundle is coming from right side. Positive and inferior lead is coming from up down from the outflow tract. Generally, they are responding to beta blocker, calcium channel blocker, and if it's not effective, then you can do a catheter ablation. Success rate is high in right ventricular outflow tract. But the most important to make here is when you see wide Caras complex and it is regular, same morphology, this is a monomorphic ventricular tachycardia. Okay, this is again the same thing. You see it's wide Caras complex tachycardia and it is regular. You see P wave here, you don't see it in other areas. There is AV dissociation. So this is a ventricular tachycardia. And if you look to this one, there is RSR in V1, so it's not typical left bundle. Okay.
Dr. Bandar?
Sure, go ahead, please.
Yeah, you said left bundle. This is left bundle or?
No, not this one. The purest one is left bundle. This one, I'm sorry, it takes a few seconds for you to see it. This is the one which is left bundle-like morphology.
Okay.
This one is the one which is more of right bundle because RS and V1.
Yeah, okay, thank you.
The next case is a 60-year-old man. By the way, if you have time later on, how to differentiate wide Caras complex tachycardia is a session by itself. So I'm just moving now common cases, but we can discuss this later in details, how to differentiate VTAC, for example, from SVT with apparency and others. Next case is a 60-year-old man, and he collapsed during exercise test. So he was still connected to 12-lead ECG. What do you think of this?
VF.
What that, sorry?
VF.
VF. This is the one that you
Yeah.
would like to see, of course, especially after cardiac surgery. So it is a VF. As you can see here, there is no distinct QRS complexes, and there is no P waves, and it's hectic. And the patient, of course, will be having no blood pressure. So if the patient is having blood pressure, what could it be? I mean, the patient is conscious, oriented, talking to you.
Artifacts.
Artifacts. Well, one of the important, especially actually, you'll see it in the post-operative patient in ICU. The leads may not be fixed well. And then you see artifacts like this, the patient is hemodynamically stable. This could not be VF or polymorphic VT. It's just artifacts. And then, by the way, generally artifacts will happen in 1 or 2 leads, not all the leads. Here you see on all the leads, there is problem. So this is a VF. Moving from tachycardia to another condition, which may cause also tachycardia, but baseline ECG is diagnostic. So this is a 32-year-old gentleman who is asymptomatic, but this is his ECG. What do you think of the ECG? What diagnosis he had?
Looks like WPW.
Why WPW? How did you make that diagnosis?
because of the what do you call it, delta wave.
Yeah, these are the delta waves, and PR is short. And the third thing is the wide QRS complex. So if you see that morphology, short PR, delta wave, you see it more obvious here in V5, V6. Look to all the leads. And this is negative delta wave in V1. So then you are making the diagnosis of Wolff Parkinson-White syndrome, which is accessory pathway that can conduct between atrium and ventricle. In this case, we call it antegrade conduction. It's conducting from atrium ventricle. If only retrograde conduction, then 12-lead ECG would be normal. And the only way to know it when you are in the EP lab and then you base the ventricle and you see conduction retrogradely through a pathway, not from the AV node. So this is a Wolff Parkinson-White syndrome ECG. Typically, they may have palpitations because they can develop SVTs, could be orthodromic, down the AV node, up the pathway. This is narrow QRS complex. Could be antidromic, down the pathway, up the AV node, and it is wide and regular. Or it could be AFib with conduction, which could be life-threatening. So for the Wolff Parkinson-White syndrome, I just explain it again. If you normally, if the sinus node start firing, activates the atria, we have a P wave. Then that P wave goes down only through the AV node, so there is some delay, and we have PR interval, which is 120 to 200 milliseconds. If they have a pathway, accessory pathway, when the impulse reaches the AV node and lower atrium, it conducts directly through the pathway to the ventricle. So lower atrium and ventricle activated simultaneously, so the PR would be very short. Second, part of the myocardium is activated abnormally through this pathway. So this is myocardial cell to myocardial cell to myocardial cell. So it would be wide, and this is what produces the delta wave. Then when they have normal conduction, because the delay in AV node is just for a short period of time, then they have the rest of the QRS complex normal. So short PR, less than 120 milliseconds, and normal P wave morphology with the presence of delta wave and wide QRS complex. This is the diagnostic criteria for Wolff Parkinson-White syndrome.
دكتور بندر معلش تعيد نقطة الدلتا ويف ليش تظهر؟
Normally why we see QRS complex is narrow because it goes down the Hess bundle from AV node to bundle of Hess, right and left bundles at the same time. So activation of the ventricle is very quick, and we have QRS complex less than 120 milliseconds. In this case, the initial activation goes through this pathway to this part of the myocardium. And to activate that part, it goes from myocardial cell to myocardial cell to myocardial cell. It takes longer time. So in that way, it would be wide QRS complex initially. When the conduction is resumed through the AV node, the rest of QRS complex is normal. So that part, which is activated through the pathway here, produces this abnormal wave that we call it delta wave.
Okay, sure.
Now, this is actually, the catheter ablation is very successful on those patients. And once the pathway is localized and ablated with radio frequency or with cryoablation, radio frequency more common, then they will have the normal PR interval and normal QRS complex morphology. Okay. Next case, a 50-year-old gentleman with end-stage renal disease and hemodialysis. By the way, we are approaching time, but we started a little bit late. So when I'm supposed to stop, just let me know, please. But we'll do one or two more cases because we started a little bit late. So this is a 50-year-old gentleman with end-stage renal disease, and he's in hemodialysis. And this is the ECG obtained in the floor. What do you think of the ECG?
I think he has atrial fibrillation with a hyperacute T wave. Could be because of hyperkalemia.
Mm-hmm. So you think the hyperkalemia is main differential. Why do you think of hyperkalemia?
Because he's end-stage renal disease, and they are prone to.
Yeah, ECG, always we interpret the ECG based on the patient condition. So first thing, end-stage renal disease, hyperkalemia should come to your mind. Number one. Number two, what do you mention, sorry?
That he is prone to electrolyte imbalance due to his disease.
Right. So with hyperkalemia, we expect few changes. By the way, in this one, what do you think the potassium level? Is it very high or just slightly high?
I am not sure actually.
Yeah, but by this, when you see this, we call sine wave, but actually very slow sine wave. Usually it's faster than this just because potassium level is high. When you see wide Keras complex like this, even if it's tachycardia, we think of potassium level more than 7.5. I'll explain the changes of hyperkalemia in a minute. So if the potassium is just above the limit, the normal limit, say 5.5 to 6.5, we have hyperacute T wave. And differential diagnosis, of course, is ischemia. When it is above that, but less than 7.5, we start to lose the P wave, and the QRS complex is wide, and the T wave is wide. Sorry, it moved. Then we have sine wave when the potassium is very high. So the changes in ECG, it depends on the level of hyperkalemia. When it is mild to moderate, mainly we see hyperacute T waves. Moderate to severe, 6.5 to 7.5, we start to lose the P wave. Still QRS complex is wide. Then when it is very, very high, more than 7.5, we see sine wave, very wide QRS complex tachycardia. Sometimes it may be irregular like the patient I showed you earlier because depolarization could not happen because potassium level was very, very high. But in patient end-stage renal disease, when you see that one, you have to act immediately in treating him. If you wait a little bit longer, he will go into VF arrest or asystole. Any question about hyperkalemia and hyperkalemic ECG changes?
Yes.
In the
Dr. Bandar, why some patients with high potassium, their ECG doesn't show significant changes? Like why?
Yeah. Mostly actually in chronically high potassium, they get used to it. So they don't have usually ECG changes, except if it is very, very high. So for example, end-stage renal disease, most of the time because they have hyperkalemia for a long time, they don't start to show changes except if the level is very, very high. So I think just because of chronicity. If somebody's potassium is normal, then suddenly elevated, most of the time you'll see some ECG changes.
Thank you.
Thank you. Next case, a 60-year-old gentleman with heart failure. He's taking Lasix, metolazone, digoxin, carvedilol, and he's on ACE inhibitors. And this is his ECG in emergency room. So what do you think? What could be the cause of his symptoms based on the ECG? Or what could the ECG show, sorry? Maybe sometimes they don't have symptoms. A little bit, this one difficult, so I'll give it to you just because...
Can I try?
Yeah, please go ahead.
I can notice that the QT interval is prolonged more than usual. And the question makes me think of only digoxin toxicity.
Okay, so long QT, remember it could be congenital, could be acquired. So if this patient, for example, has congenital long QT, it will be still long. However, there are other changes with this long QT. Did you notice it? It's not only QT is prolonged. The T wave here, you see how it's flat? And
yes,
this is another hump after the T wave ends. What do you call that one before P wave? It's called the U wave.
U wave.
So if you see a U wave and flattening of the T wave in heart failure patient who's taking aggressive diuresis with Lasix and metolazone, you should think about hypokalemia. So hypokalemia would be the most likely. And in this case, again, the history is very helpful because this could be just congenital long QT, for example. It could be long QT for medications or other things. But when you know the scenario, this patient is taking aggressive diuretics, I mean, Lasix, metolazone, commonly associated with hypokalemia, then you see the changes are typical for it. QT is prolonged, T wave is flat. Sometimes you see ST segment depression, and then the presence of U wave. This is the typical changes of hypokalemia. ST segment depression, flattening T wave, and the presence of U waves. Okay, so that actually hyperkalemia, hypokalemia ECG changes. Another electrolyte issue here. A 36-year-old lady, she's having palpitations, and she's known to have hyperparathyroidism. And this is the 12-lead ECG. What do you think of the 12-lead? What is the main abnormality here in the 12-lead ECG?
the ECG overall has a low voltage,
Mhm.
and
Maybe in the limb leads, but the chest lead is okay there. You see, it's more than 10. Generally, we look for 5
Yes.
in limb leads and more than 10 in chest leads, and this is more than 10. Yeah.
there is also ST abnormality in V3.
In lead 3,
And V3.
V3, yeah. Okay.
Yeah.
And 4, 5, yeah. Does it look like
Yeah.
the same as ischemic ECG I showed you before? Or does it look like typical ischemia, this changes?
And the curve of the ST is not the one we see in ischemia usually.
And you see there is a notch there, yeah? You see that small notch?
Yeah.
There is a notch here in the J point. So actually this is called early repolarization. It's not actually what I'm asking about, just because it is good to have, you came through it. It's a young patient with these ECG changes, typically early repolarization, which is most time, benign. There is now one condition, early repolarization syndrome, that could be malignant, but it is very small, and there is case reports about it. But generally, young patient, you may see this concave type J point. There is notch there. T wave is upright. We call it early repolarization. But the question here is about this. Actually, if you look to the QT here, is very short. Agree with me? That QT is very short. It looks short. So short QT, we have two differential diagnoses. One is hypercalcemia, like this patient with hyperparathyroidism, and this is again when the history is helpful. And the second is we call it short QT syndrome. We know that we have long QT syndrome is there for a long time. We have short QT syndrome, which is rare disease. Maybe there's about 200 case reports in literature. It again can cause VF. So in this case, with a patient with hyperparathyroidism and short QT, you have to suspect hypercalcemia. And actually this was the case, so hypercalcemia. And then of course you will confirm it by doing the lab test and then treat accordingly. So this is a case of hypercalcemia. It's less important, by the way, to know, but there's no hypo and hypercalcemia can cause ECG changes. In hypocalcemia, you have QT prolongation. Typically, the ST segment is flat like this, and then you have T wave at the end. In hypercalcemia, the opposite, it causes shortening of the QT interval. Do we have time for one or two more cases?
Yes دكتور, I think yes. I've been calling دكتور عبد الرؤوف. دكتور عبد الرؤوف, أستاذنا تسمعني؟ I think we can continue. Doctor, can you give me just 1 second? Doctor, go on. I will talk with Dr. Abdul Rauf now. Please.
دكتور بندر تقدر تكمل على بال ما هو يكمل دكتور عبد الرؤوف.
أيوة. دكتور بندر خذ راحتك. دكتور عبد الرؤوف معنا و also he's enjoying your excellent presentation. تفضل دكتور, خذ راحتك.
We'll take this case and then we'll stop if you don't mind. So this is a 40-year-old man with heart failure, end-stage renal disease, and dialysis, and he's in ER with nausea and vomiting. So what do you think of these possible differential diagnoses?
It looks like the rhythm is irregular. There is no P wave, so probably maybe atrial fibrillation.
So this is atrial fibrillation also, because once you don't see P wave and rhythm is irregular, narrow QRS complex, number one diagnosis is atrial fibrillation. Yeah.
Yes, and there are T wave inversion in the high lateral leads, also in the septal and lateral lead, V4 and V5 and V6. Maybe there is a lateral ischemia.
Okay, so one of the differential diagnoses, I agree with you, could be ischemia. So now go back to the scenario. This is a man with end-stage renal disease and dialysis, and he has nausea and vomiting in emergency room.
Hi, Dr. Kalim.
I would think of medication toxicity also.
So what kind of medication that cause this?
I would go with the digoxin toxicity because of some multiple ECG changes, which is typical for digoxin toxicity.
Yeah, excellent. So actually, as I said earlier, some ECGs, you have to have the scenario and then think about all the possible differential diagnosis. So this is a patient with atrial fibrillation, and you know, digoxin is one of the rate control medications that is used. It has narrow therapeutic window, and mostly in patients with end-stage renal disease, we try to avoid it because they can go into toxicity easily. The first manifestation of toxicity is nausea and vomiting. So if you see patient with digoxin in emergency room, with nausea and vomiting, you have to think about digoxin toxicity. The changes here actually in the ECG is typical for digoxin effect or digoxin use. They typically have ST segment depression, T-wave inversion as one segment. Is different from the ischemia that we have it before. And so down gradually sloping the ST segment and the T-wave. This is called scoping. If you see this in ECG in a patient with AFib, mostly we think the patient is using digoxin. So it is not a digoxin toxicity manifestation. However, the history there, when it tells you that he has nausea and vomiting, then you have to think about digoxin toxicity. Digoxin toxicity can present with anything, actually, tachy or bradyarrhythmias. Typically, they present with junctional tachycardia, but they may have any tachy or bradycardia. But initially, when you see ECG with these changes, you suspect that the patient is using digoxin. Next slide actually will just show you that what I mean. It's gradual down sloping of the ST segment and T wave. And when you see that one is different from ischemia, this indicates that the patient is using digoxin. So it is just digoxin effect. But if the patient is having nausea, vomiting, his end-stage renal disease and taking digoxin, you have to think about digoxin toxicity. I would stop here. Thank you very much for listening. And if there's another time, we can go for other cases, inshallah.
دكتور بندر one question. بالنسبة لل WBW, do we usually ablate those patients, يعني especially if they are asymptomatic?
Asymptomatic is controversial. Some people, they think we at least need to do electrophysiology study and assess the conduction down the pathway. If it is weak, there is no need for intervention. If it is strong conduction, there is risk of AFib with fast conduction and ablate them. Other people think if there is no symptoms, just observe the patient because the risk of mortality is very low, 1 in 1,000. So they just follow patients. So it depends on the symptoms and depends on discussion with patients. So if patient is very anxious about it, even if no symptoms and he agrees to go for AB study, we first assess the conduction, and if it is fast, we go for ablation. Not fast, we just if the patient is absent and doesn't have symptoms, we just continue following them in the clinic.
Okay, sure.
Thank you very much. I'll just stop sharing here and then.
Thank you very much, Dr. Bandar. We were honored to have